Assalamu alaikum warahmatullahi wabarakatuh. My pleasant greetings to all the members of this GDP family. I'm Dr. Mohammed Ghouse. I'm a consultant oral and maxillofacial surgeon. So today I'll be talking about inferior alveolar and lingual nerve injuries. Although this topic should be spoken under the umbrella of trigeminal nerve injuries, I would like to Uh, it's not very often that we see injuries in the other branches of trigeminal nerve. So I thought this would be more relevant for the people who are practicing impactions and also for endodontists, specifically if uh, there have been cases where there's been over obturation of the root and which has led to inferior alveolar nerve paresthesia. So that is that. So I thought this topic would be of an interest. So before starting this topic, I would talk about the relevant anatomy of inferior alveolar nerve and lingual nerve. So as we all know, the inferior alveolar nerve and lingual nerve are branches of mandibular nerve, specifically the posterior division of mandibular nerve, which in turn is a branch of trigeminal nerve. As we all know that trigeminal nerve provides the neurosensory innervation to the face. So if we say in this diagram, the mandibular nerve emerges through the foramen ovale, has its main trunk, which divides into its anterior division and the posterior division. So the anterior division mainly supplies the muscles of mastication, whereas the posterior division has three branches. That's the auriculotemporal nerve. That is, it has a sensory innervation over the skin of temple. Then we have the inferior alveolar nerve, as we can see here, and this is the lingual nerve. So the inferior alveolar nerve, before entering the mandibular foramen, gives off a branch which is nerve to mylohyoid, which supplies the mylohyoid muscle. Then it enters the mandibular foramen, supplies the pulse of molar teeth and the premolar teeth, and comes out of the mental foramen as mental nerve, which supplies the skin over the chin and the lower lip on the ipsilateral side. Whereas if you see the lingual nerve, it supplies the lingual mucosa, floor of the mouth, and ipsilateral half of the anterior two-thirds of the tongue. So lingual nerve has both general sensation as well as special sensation. The special sensation is mainly taste, which is derived from chorda tympani, which is a branch of facial nerve. We can see in this diagram that chorda tympani joins the lingual nerve, which forms a conduit for the branches of chorda tympani to for taste sensation in relation to anterior two-thirds of the tongue. So coming to the surgical anatomy of inferior alveolar nerve and lingual nerve. So in this diagram on the left, we can see that the inferior alveolar nerve can either be lingual, as seen in this diagram, buccal, or inferior. But most commonly, it is on the buccal aspect of the mandible. And the other variations include it can travel either between the roots of the third molar or it can be separate from the roots of the third molar. So, and coming to the lingual nerve, if you see mediolaterally from the lingual crest, it is on an average present at a distance of 0.58 to 3.45 millimeter, and superior inferiorly from the alveolar crest opposite to that of the third molar, that is 2.28 to 8.23 millimeters. So few things I would like here to mention is that the inferior alveolar nerve is often present buccal. So uh, at the distobuccal region, it is slightly at a higher level when compared to that of mesobuccal region because it is coming in a downward fashion. So especially during impactions when we are performing the buccal guttering or the buccal osteotomy in order to relieve the tooth from the bone, and so there's more chance of injury of the inferior alveolar nerve if we try to gutter deeply at the distobuccal aspect. So this has to be taken very special care of, and the also if there's inferior alveolar nerve injury, there's a rigorous hemorrhage from that particular site, which has to be managed mainly by means of pressure or using bone wax if pressure is not able to, if we are not able to apply enough pressure to stop the bleeding. We cannot use a cautery in that region to control the bleeding because again it can induce significant nerve damage, and also we cannot use other chemical methods of stopping the bleed. So our best bet would be either pressure or it would be use of bone wax. So this was one important point. And uh, mm, for in the lingual nerve, especially for the lingual nerve, especially during the incision placement. So the classical Terence Ward's incision has three components. That is an anterior release incision just mesial to that of the second molar, then a clavicular incision and a distal release incision. So the significance of this is sometimes there's an abnormal pathway for the lingual nerve, that is it is exactly present on the retromolar pad. And for the distal release incision, instead of carrying it laterally over the external oblique ridge, if we carry it straight, there's a high chance that we might transect the lingual nerve. So these are the few points which we need to keep in mind. So coming to the various causes of injuries of inferior alveolar nerve or the lingual nerve so the most common dental procedures which can cause these kind of injuries are extraction of third molars, especially if they're in close proximity to that of the inferior alveolar nerve, or if adequate care is not being taken and there's poor soft tissue handling, especially on the lingual side, then we have a high incidence of these injuries. Implant placement, again, implant placement, if the osteotomy is over prepared and the implant is over drilled into the osteotomy, then there's a high chance that it can cause inferior alveolar nerve injury. Then endodontic treatment, the apices of the second molar and the first molar are in very close proximity. That is approximately 2 millimeter of bone is separating the inferior alveolar nerve from the uh, apices of second molar and first molar. Hence, care must be taken not to over instrument the tooth and not to over obturate, and use of irrigants, specifically hypochlorite in those regions with very much care. Also in orthognathic surgeries, especially the mandibular advancement or setback surgeries done by the means of bilateral sagittal split osteotomy, this has higher incidence of inferior alveolar nerve injury. Trauma, facial fractures, especially mandibular fractures, especially fractures of body of the mandible and angle of the mandible. These usually cause inferior alveolar nerve injuries due to they can either cause transection or stretching of the inferior alveolar nerve. Then again, iatrogenic injuries, especially during nerve lateralization procedures, which was earlier done, now it's more or less outdated. Other reasons for inferior alveolar and lingual nerve injuries include uh, any odontogenic tumors when they are usually what they do is they encase the inferior alveolar nerve, whereas a cyst it compresses the inferior alveolar nerve or the lingual nerve. And also, while enucleation of the cyst, when we try to separate the cystic lining from the inferior alveolar or the lingual nerve, there's a high chance of injury to these nerves, which can it if especially if there's blind instrumentation being done. And also infections. One particular infection I can think of is osteomyelitis of the mandible, where it causes significant inflammation and edema of bone marrow spaces, which in turn causes compression of the inferior alveolar nerve and causing more of a neuropraxic type of injury, which I'll be talking in the further slides. So there's one very prime classification of nerve injuries, which is the Seddon's classification. There's another classification, which is the Sunderland's classification. So Seddon's classification, basically, it has a central axon and a neuronal sheath. So the neuronal sheath, so based on the so he has classified in nerve injuries as neuropraxia, axonotmesis, and neuronotmesis. So in neuropraxia, there's either traction or compression of the nerve, and but there's no loss of continuity of the nerve, as we can see in this image. Whereas in axonotmesis, there's disruption of continuity of the axon, whereas the neuronal sheath is intact. Both neuropraxia and axonotmesis carry good prognosis. Especially neuropraxia has a better prognosis, which the nerve recovery usually takes place from few days to few weeks, whereas in case of axonotmesis, it usually takes place from few weeks to few months. Whereas in neuronotmesis, the prognosis is poor because there's complete transection of the neuronal sheath as well as the axon. So coming to the clinical features of inferior alveolar nerve and lingual nerve injuries. So inferior alveolar nerve injury mainly presents as hyposthesia, that is reduced sensation, or paresthesia, that is altered sensation, which mainly in the form of tingling, or dysesthesia, that is altered sensation mainly in the form of pain. So as we can see in this diagram, there may be ipsilateral numbness on the same side, or uh, with or without altered sensation or pain. Whereas in cases of lingual nerve injury, we see that there is ipsilateral loss of sensation. There can also be dysesthesia, that is painful sensation, and one more very classical feature is loss or altered taste sensation in anterior two-thirds of the tongue. As I mentioned in the earlier slides, that taste sensation to the anterior two-thirds of tongue is by lingual nerve by chorda tympani. So there are various steps which preoperative steps which we can take in order to reduce the risk of nerve injuries, especially the inferior alveolar nerve and the lingual nerve injuries. So Rudenschab's radiological criteria, this is on a 2D radiograph. So basically he gave 8 criteria, that is darkening of the root, deflection of the root, narrowing of the root, dark and bifid apex of the root, interruption of the white line of the canal, that is the superior cortex of the canal, diversion of the canal, and narrowing of the canal. So if we see any of these signs on an orthopantomogram, it is necessary for us to take a three-dimensional scan such as a CBCT scan to assess the relationship of the inferior alveolar nerve with that of the apices of the third molar. So uh, other technique and for lingual nerve, the only thing which predicts that there could be a possible lingual nerve injury, that is now especially in cases of lingually placed third molar, which can manifest as a target sign on a radiograph. So coming to the diagnosis and management of these nerve injuries. So this particular article in the British Journal of Oral and Maxillofacial Surgery has comprehensively given on the current management techniques uh, in cases of damage of inferior alveolar nerve and lingual nerve. Even though this was given in the year 2004, it still holds the most of the methods, that is the monitoring methods as well as the management methods, they still hold good. So in the introduction part of this particular article, so he has mentioned few points that patients who are left with a minor degree of hyposthesia, that is reduced sensation or mild paresthesia, they usually cope up well with the sensory deficit. Whereas in contrast to the patient who have substantial sensory deficit or dysesthesia, usually these are the patients who are suitable candidates for microsurgical repair. So the first thing to do is clinical examination. So clinical examination done is usually in the post-operative phase. And the clinician usually becomes aware only after a week of the injury. Uh, the only reason I can think of this as to why they come only after a week is because they patients usually think that maybe it's because of it is a normal post-operative sequelae. Honestly, I don't know why he has given this line, but anyways, so he also has mentioned terms such as evoked response and spontaneous response. What is its importance? What is complete anesthesia? So he has said that evoked responses basically when you try to mechanically stimulate that region innervated by the inferior alveolar or the lingual nerve, patient will present with a tingling sensation. So in this indicates that there is some degree of nerve injury, but there is no complete transaction of the nerve, and the prognosis associated with it is good. Whereas if there's a spontaneous response, it doesn't correlate with the prognosis per se. It just shows that there is some sort of nerve injury, but and there's some sort of nerve activity going on. So, one important anatomical factor which I would like to mention here about the inferior alveolar nerve is the inferior alveolar nerve, as we can see in this small schematic diagram, is traveling inside a bony canal. So, the importance of this bony canal is the cut ends can only grow towards each other and cannot grow anywhere in any other direction. So because of this, the inferior alveolar nerve carries a much better prognosis after injury when compared to that of the lingual nerve. And also, even if there's complete anesthesia, that is entire loss of sensation in case of inferior alveolar nerve, the prognosis is better because the cut nerve ends can basically grow towards each other and thereby carry a better prognosis as compared to that of lingual nerve, which entirely lies in the soft tissue. Hence, this has to be kept in mind. So, in this radiograph on the top right side, so in cases of inferior alveolar nerve injury, when there's complete anesthesia, it warrants for a radiological study. So that is, we either obtain a two-dimensional or a three-dimensional radiograph, mainly to see the continuity of the canal, or if there are any fragments which are lodged into the canal causing this anesthesia, and this warrants an immediate microsurgical decompression in order to remove the fragment.
So, the monitoring of injury can be broadly classified into mechanoceptive methods and nociceptive methods. So, the mechanoceptive methods include light touch, brushstroke discrimination, two-point discrimination, whereas the nociceptive methods include pinprick and thermal discrimination. So, in order to do this, first we have to define the region of injury. So this is the upper lip, this is the lower lip, this is the chin. So we draw one line starting from the lower lip to the chin, another line starting from one end passing between the lower lip and the chin, which essentially divides the area between the lower lip and chin into four quadrants. So this becomes the first quadrant, second, third, and fourth. Suppose the injury is on the right side, that is corresponding to the first and fourth quadrants. First, what we need to do is we need to establish the normal baseline for any testing. So we start with the mechanoceptive methods, starting with light touch. Basically, we can use either a fine head brush or a wisp of cotton. Patient is asked to close his eyes, and the wisp of cotton or the tip of the brush is gently placed in on the unaffected region. That is basically, example, in the second and suppose there's injury in the first and fourth quadrant, we would place the cotton on the second and third quadrant, and we ask the patient whether he is able to perceive this touch or not. So any abnormal response should be noted. Then coming to the brushstroke discrimination or brushstroke direction, again we can use either a fine haired brush or a wisp of cotton, and a normal baseline has to be established. So the wisp of cotton is either passed from right to left or left to right. In the normal region, this establishes the baseline, that is, the patient should be able to perceive the direction of the cotton. If he or she is not able to perceive, it should be marked as abnormal. Then coming to two-point discrimination, two-point discrimination can be done either with the help of a vernier caliper or a divider. So what the basic thing in two-point discrimination is, it shows that the integrity of the larger A beta fibers which carry the touch sensation. So what they do is they place 2 points of an instrument over the affected region and the unaffected region. So the patient should be able to perceive these 2 points distinctively. So if he or she is not able to perceive these 2 points distinctively, then it indicates that there is loss of 2 point discrimination in that region. So the normal 2 point discrimination distance for inferior alveolar nerve is 4 millimeters, whereas for a lingual nerve is 3 millimeters. So that means to say that anything below 4 millimeters along the distribution of inferior alveolar nerve, if you place uh, these two, suppose if you place these 2 points, this distance between this is 3 millimeters. So the patient won't be able to perceive it because the normal 2 point discrimination distance for inferior alveolar nerve is 4 millimeters. So anything above 4 millimeters, he would be able to perceive it as two distinct points, whereas anything below 4 millimeters, he would be able to perceive it as only a single point. So in cases of a nerve injury, this normal 2 point discrimination distance is affected. So even at 4 millimeter, the patient won't be able to appreciate two distinct points. And we have to keep increasing it in the increments of 1 millimeter. Suppose we say that we start the baseline at 4 millimeters on the unaffected side. Then on the affected side, we do the same, start with 4 millimeters, and we assess patient's response whether he's able to perceive two distinct points or not. If not, then increase it to 5 millimeters, then 6 millimeters, and keep it increasing till the patient is able to perceive two distinct points. So this has to be recorded, and this monitoring has to be done every month to see whether this distance is reducing or not. Then coming to the nociceptive methods of monitoring. So we can either use a fine needle or so basically what they do is they probe the or we can use a probe. So we probe the affected region and the unaffected region. The thing is, in cases of injury of the inferior alveolar nerve, the patient will perceive it as pressure on the affected region, whereas on the unaffected region, he would be able to perceive it as a prick. So this has to be recorded. Then coming to thermal discrimination, again we can it is divided into two: hot and cold thermal discrimination. Hot thermal discrimination, what they do is they heat up a gutta percha stick, allow it to cool down, and place it on the unaffected region first. They establish the baseline where the patient is able to perceive this or not. Then they place it on the unaffected region. So basically, these nociceptive methods uh, uh, they show us whether they show the integrity of A delta and B fibers. A delta and C fibers which carry pain sensation from the periphery. Uh, so and for cold discrimination, we can use a cotton pellet soaked in an ethyl chloride spray, and the again same thing. So basically, we place it on the unaffected region, then on the affected region, and we ask the patient whether he's able to perceive this or not. So how often this monitoring of recovery has to be done? So according to this article, he has said that the monitoring has to be done every month for the first 3 months to see whether the patient's status is improving or not. And when do we refer this patient for microsurgical repair? So suppose we've done the testing for up to 3 months and still we see that patient's condition is not improving or patient has developed dysesthesia. So that is a strong indication that we need to refer the patient for a microsurgical repair.
So how do we manage it? So we can broadly divide them into conservative and surgical modes of management. So the first thing, the conservative methods, especially the pharmacological management, the most common drugs which we use are corticosteroids and antioxidants and vitamins and a few agents to in order to reduce neuropathic pain, which I'll be talking further. So corticosteroids, especially prednisone and dexamethasone, can be used. So their basic mechanism is this is usually used in the initial phase, that is immediately in the post-operative phase, in order to reduce the inflammation by suppressing the inflammatory response. So it is a very potent anti-inflammatory agent. So suppose we are starting with an initial dose of 8 milligram, then for short doses we usually don't need to taper it. But if we are using higher doses, then we need to taper it. And usually for these kind of injuries, we use it for a period of in the acute phase, that is for a period of 5 to 7 days. Then we gradually taper the dose. That is, the dose has to be tapered 50% that after 3 days. Suppose we've started at 8 milligrams for a week. Then we need to reduce it to 50%, that is 4 milligrams after 3 days. Then after 3 days, 2 milligrams. Then after 3 days, 1 milligram and zero point 0.5 milligram, and then finally stop. We cannot suddenly stop it, but because there's a risk of hypothalamo pituitary axis suppression, which can lead to adrenal insufficiency. So, the various side effects of corticosteroids include immunosuppression, hyperglycemia, osteoporosis, and adrenal suppression when they're used for a longer duration. Uh, Other antioxidants and vitamins such as alpha lipoic acid, vitamin B complex, B1, B6, B12, commonly available as Neurobion or Neurobion Fort. Neurobion Fort is basically which has more uh, levels of B1, B6, and B12 compared to just Neurobion. So basically, they protect the nerve cells from oxidative stress and support nerve repair and nerve regeneration. So, Neurobion Fort, we usually give it as an initial dose of that once a day it is given for a period of 1 month, followed by once a day every alternative day for another 1 month. So, uh, so side effects are usually well tolerated and they don't have potential side effects. There are few cases of neuropathic pain, especially dysesthesia, in cases where the patient is not fit for surgery, or in cases where the patient is a poor candidate for surgery. So we can use drugs such as amitriptyline or nortriptyline. Basically, they modulate the neurotransmitter levels of serotonin and norepinephrine centrally in order to alleviate the pain. So dosage can be used 10 to 75 milligrams daily. So side effects of these include sedation, daytime sleepiness, dry mouth, weight gain. So these have to be given with cautions, and people who are they are usually taken during the night and not during the day. Uh, we can also use anticonvulsants to stabilize the nerve cell membranes and inhibit the abnormal nerve reflexes or impulses in cases of neuropathic pain. So most commonly, gabapentin can be given for a period of 10 days. So this stabilizes the nerve cell membrane, and if associated with any if the neuropathic pain is often subsides. So side effects are similar to that of antidepressants, which include drowsiness, dizziness, weight gain, peripheral edema. The other options include topical analgesics. That is, we can either use lignocaine patches or capsaicin cream, which provide the local numbing effect. There are also new modalities where they have tried nerve regeneration or growth factors in order to facilitate nerve regeneration. Surgical interventions include nerve decompression, neurorrhaphy, or nerve grafting. Nerve decompression is basically if uh, in complete anesthesia of inferior alveolar nerve, sometimes what happens is the bony fragments, they get lodged into the canal, causing this complete anesthesia. In such cases, we have to do an immediate microsurgical decompression where we remove the fragment in order to relieve the nerve from the pressure. Also, in cases of implants where the implants have been directly placed onto the nerve, so they say that within 36 hours, these implants have to be retrieved uh, because beyond that, the prognosis often deteriorates. And neurorrhaphy, that is basically the nerve repair. So when there's complete transection of the nerves, there's often formation of scar tissues. So this scar tissue has to be excised. The nerve stumps have to be refreshened. If the distance between them is less than 3 millimeters, then a primary neurography can be performed. That is, these nerve ends can be approximated, and they can be by means of either ethylene or a proline 90 suture under the microscope, because these sutures are very small. And if suppose the distance between those cut two ends is bigger, that is greater than 3 millimeters, then we can either use nerve conduits or grafts. That is, the uh, grafts can be used either from the post-auricular region, where the great auricular nerve graft, it has a similar diameter to that of the inferior alveolar nerve. So, in order to reduce the distance, this graft can be placed in between, and those two ends can be sutured together. So, coming to the timing of repair in this particular article and a study done by Ridger et al., they have mentioned that nerve repair done within 1 year of transaction carries a better prognosis as compared to beyond that. Another thing would be management of dysesthesia. Which one would be better, surgical or medical? So, uh, in this article, they have stated that even though surgical method of management, it doesn't reduce the number of cases, but it reduces the intensity of the symptoms. So surgical method is preferred over the medical method. So if surgical method fails, then we can go ahead with the pharmacological management by means of uh, agents which I mentioned earlier, such as antidepressants, or we can also use, there are a few studies which they've also used carbamazepine, but carbamazepine, the adverse effects associated with it is much higher. So we also need a baseline liver function test for, especially if we are putting the patient on carbamazepine, and then we have to frequently monitor the patient's liver function test. So in summary, for this is a schematic which shows us how to manage inferior alveolar nerve injury. So suppose after removal of lower third molar, if we see that there's transection of the nerve during the operation, then it warrants for an immediate repair. If the since most of us are not trained in microsurgical repair, it needs an urgent referral. Suppose the patient comes in the post-operative phase with complaints of either paresthesia or anesthesia. So for anesthesia, a radiograph has to be obtained. uh, I would prefer a three-dimensional radiograph, basically to see whether if there's any bony fragment lost within the canal, or if something is interrupting the continuity of the neurovascular bundle. So if there is a bony fragment which is impinging, causing complete anesthesia, it warrants for a microsurgical decompression. If not, the management is similar to that of paresthesia. So in paresthesia, what we do is we initially monitor the recovery monthly for minimum of 3 months. So these are done by means of mechanoceptive and nociceptive testing by means of light touch, pinprick, and two-point discrimination. After 3 months of injury, if there's some sort of recovery, we continue to monitor. But if there's no evidence of recovery, it
Then if, after 3 months post-injury, there's limited further recovery or no evidence of recovery, then we should consider for microsurgical repair. So the indications for microsurgical repair would include significant hyperesthesia or dysesthesia, or if the patient wants to undergo the procedure. However, the success rate of microsurgical repair, even if it's done best, is up to 70%. So the pros and cons have to be weighed and have to be discussed with the patient. For lingual nerve injury, the management method is similar. One thing I would like to mention for a lingual nerve injury is how to monitor it. So initially the patient, the clinical examination has to be done, and the patient uh, is usually asked to point out as to the amount of region which is being affected as because of this lingual nerve injury by means of his finger. So suppose after removal of third molar, division of lingual nerve is noted during the procedure or intra-op. it warrants for an urgent microsurgical repair. Suppose if there's lingual nerve paresthesia or anesthesia in the post-operative phase, so we need to assess if the paresthesia is stimulus evoked or if it's spontaneous. And then we have to monitor its recovery for monthly for up to a period of 3 months. Even for anesthesia, we monitor the patient monthly for a period of 3 months. So, suppose after 3 months of surgery, there is evidence of recovery, we continue to monitor. If there is no evidence of recovery, it warrants for a microsurgical repair. Or even if after 3 months of monitoring, there's limited further recovery, it warrants for a microsurgical repair, considering the patient is willing to undergo the procedure and now, and it actually warrants for a microsurgical repair. Not all cases warrant for a microsurgical repair. Only, as I mentioned earlier, only cases where there's significant hyperesthesia or dysesthesia which affects the day-to-day quality of patient's life. Only such patients are suitable candidates for microsurgical repair. That is included, their general health supports it. So this was my presentation on the inferior alveolar and the lingual nerve injuries. I hope I could explain it to you the process of monitoring and management and how to go about it. So thank you very much. Thank you for providing me this platform in order to share my thoughts on this particular topic. Thank you.